Millions of women give birth every year, many of them for the first time. And though there are pregnancy books and birthing plans, can someone ever be truly prepared for childbirth? While it may seem like a one-woman show, having someone to monitor the process can be invaluable during delivery. A growing choice for many mothers has been to hire a doula.
A doula is a non-clinical professional who's trained in the areas of childbirth, and a doula will support a mom through pregnancy, labor and birth, and postpartum. So a lot of the trainings is hands-on experience. It's also just having the knowledge from the bookwork. And then also there's a lot of community and advocacy done in some of the doula trainings as well, so we know how to advocate for the people we're serving.
That's Nicky Dawkins, a full-circle holistic reproductive health doula. She speaks with mothers during pregnancy to establish a clear communication plan for when it's time to give birth.
Depending on what you tell me, I will usually come to you and give you some labor support and help you with pain relief techniques, and also just managing the process and making sure that you know what your body is going to do next. After that, as your labor continues, we go to your birth location, whether that's a hospital or a home or a birthing center, and I'm there to labor with you until your baby comes.
Doulas train expecting mothers in body literacy education, so they're not surprised with how their bodies react when giving birth. Dawkins says this training helps lessen the chance of needing any interventions during labor. In fact, the American College of Obstetricians and Gynecologists has said the continuous presence of a doula is one of the most effective tools to improving labor and delivery outcomes.
It's the knowledge we give the mothers, but also being there in person to advocate for them in the birth setting. So should something come up, whether an intervention is needed or is optional, a doula can really help kind of bridge the gap between the provider and the patient, so they fully understand and have time to make an informed decision about what they want to do in their birth process.
Perhaps a delivery is being rushed, or the patient receives an epidural too soon. A doula is trained to notice abnormalities and get the process back on track with the mother's plan.
They'll come in and they'll be in their labor, and the doctor will say, "You're not progressing fast enough. Let's get you on Pitocin." Or, "Are you having pain yet? Oh, you should get the epidural now." And if that's not something that they want to do, that's kind of where I can kind of give them the empowerment to use their voice and speak up for what they want, and also to have the knowledge to know what they're talking about with their provider as to what they want.
While doctors are wanting the best outcomes for their patients, sometimes information slips through the cracks. When these mistakes occur during a pregnancy, it can be life-threatening.
Some recent data indicates that maternal mortality rates are trending in the wrong direction in the United States. And estimates of maternal mortality in the U.S. range from the absolute numbers about 700 to 900 maternal deaths per year occurring in the United States. And that's a rate of about, depending on whose estimate you're looking at, about 17 to 26 per 100,000 live births. In the UK, that number is 9, and in Canada, just 7.
That's Dr. Lindsay Admon, an assistant professor of obstetrics and gynecology at the University of Michigan Medical School. Maternal mortality refers to the death of a woman during pregnancy, at delivery, or less than a year after the end of a pregnancy. Admon says we're one of the only developed nations with a rising maternal mortality rate, a trend that was widely noticed about 6 years ago.
When this data was coming out about how high our rates of maternal mortality are, not all states had functioning maternal mortality review committees to review cases of maternal death to help us really understand when these deaths are happening or what is causing them. At that time, generally speaking, a smart decision was made by the Centers for Disease Control and Prevention in that they decided to help the infrastructure of maternal mortality review committees in different states.
Admon says that these review committees have begun providing important data that, for the first time, is letting us know what's causing these deaths.
What we're learning, and I think a big contributor to the trends that we're seeing, is that we don't have the same population in the United States that we had 50 years ago. Individuals giving birth are being diagnosed with chronic conditions like obesity, hypertension, diabetes at younger ages. Those all contribute to higher rates of pregnancy-related complications. In addition, we're one of the only countries in the industrialized world that doesn't have paid maternity leave or, sort of a guarantee for coverage later into that post-insurance coverage later into that postpartum year.
Which could be a factor in these deaths. Admon says data from the review committees show large increases in the number of deaths happening after childbirth.
I think when this news first came out, a lot of people thought, oh gosh, there's this narrative of more and more women dying during childbirth. And while that's part of the problem, a big part of the problem is that people are also dying later in that first year postpartum.
In an effort to figure out why American mothers are dying, Admon and her colleagues conducted a study that was recently published in JAMA Network Open. They examined pregnancy-related deaths that occurred within a hospital.
So about half of all cases of maternal mortality will happen in the hospital. And what we found was that basically a large proportion of maternal deaths are actually occurring during hospitalizations that happen earlier in pregnancy or postpartum. So not necessarily during that delivery hospitalization.
Their research shows that postpartum hospitalizations only cover 10% of all hospitalizations. However, they account for about half of all maternal deaths in hospitals.
So I think what that tells us is not only outside of the hospital, but inside of the hospital too, we need to direct some of our initiatives to improve quality of care and maternal health outcomes, not only to the time of delivery hospitalization, but towards hospitalizations that happen earlier in pregnancy and later in pregnancy in the postpartum period as well.
Though it's not currently an area of her own research, Admon says there are various policy interventions that could improve maternal health outcomes.
One of those is coverage of doula support for individuals giving birth, particularly minoritized individuals who may face increased barriers to high quality care. And part of it is that sense of having someone you can rely on with you during your hospitalization, but also somebody who can advocate for you and say, hey, I think something's wrong. I'm going to help you speak up about that.
There's evidence that women of color who give birth in America are more at risk for complications. The CDC reports that from 2007 to 2016, Black and Native American women had significantly more pregnancy-related deaths than white, Hispanic, and Asian women. The reports show that these disparities persisted across age groups, education levels, and even in states with the lowest maternal mortality rates. Dawkins says that's why it can be helpful to have a professional from your own community who understands your culture.
If you have a community doula, somebody who's like you in your community, they understand your needs, they know what resources to give you, they understand the area that you live in and what that can mean for your birth process. And also just having a full understanding of that patient and what they want to do with their birth based on their culture and their background can be really beneficial, because a lot of times when somebody does have a baby or gets pregnant, they might be meeting that provider or person for the first time. They might not have any relationship to them, or they might be completely different from them. And sometimes having somebody who is like you can make you feel more comfortable and give you a better outcome with your birth process.
Another intervention that's already proven to be effective is called the Alliance for Innovation on Maternal Health, also known as the AIM program.
What the AIM program did was develop a bunch of quality of care bundles. So lists of steps that hospitals or health systems could take to improve maternal outcomes in a certain area. So there's one for hemorrhage, there's one for hypertension in pregnancy, and those are two of the most commonly implemented bundles that they have, that many hospitals have instituted widely, that have helped improve outcomes.
Admon says that many of the deaths occurring later in the first year postpartum are related to mental health conditions. Mothers may develop anxiety disorders, depression, or even substance use disorders.
Part of what we believe is driving this problem is that half of all births in the United States are covered by Medicaid. And historically, pregnancy-related Medicaid coverage has ended at just 60 days postpartum. And a lot of these deaths are happening later than that 60-day mark. And if you can imagine, if you have postpartum depression or, a substance use issue that's in remission, then at 60 days postpartum, all of a sudden you lose that connection with your provider, with your prescription medication.
She says there's a big push to extend Medicaid coverage through the entire first year postpartum to prevent maternal deaths. Interestingly enough, the COVID-19 pandemic served as sort of a case study for this theory.
So during COVID-19, starting in March of 2020, Medicaid programs were not allowed to drop enrollees. And unanticipated consequence of that was that folks who have given birth since March of 2020 on Medicaid have been continuously enrolled in Medicaid since that time. So there's always a little bit of lag in data. So 2020, 2021 data, some of the data sets that I use from those years is just now coming out. And we're really excited to jump into that data and see if there has been an improvement in maternal health outcomes during that period.
Which at the moment is Admon's greatest research interest and a motivation for her entire career in women's health.
My mom passed away when I was really young, and she was a single parent, so that was like a pretty dramatic change in my life and sad. And I think when the data came out about moms dying for pregnancy-related causes, I had a lot of empathy for the families and the children who are being left behind.
You can find more information about Dr. Lindsay Admon, Nicky Dawkins, and all of our guests on our website, radiohealthjournal.org. Our writer-producer is Kristen Farah. I'm Reed Pence. This segment was brought to you by Capital One. With one of the best savings rates in America, banking with Capital One is the easiest decision in the history of decisions. That's banking reimagined. What's in your wallet? Terms apply. See CapitalOne.com/bank for details. Capital One N.A., member FDIC. Coming up next week on Radio Health Journal.
A lot of people do think of education as about teaching, but I think they'd be better off thinking about it as learning. Learning is about what the students actually take away from it.
Is our education system focused too much on teaching?
Then, is anxiety the villain in our story?
What we have done is nowadays in our society, since we've lumped fear and anxiety as one thing, people don't listen to their anxiety.
All that and more on Radio Health Journal.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
35% are at risk for anorexia, 58% are at risk for bulimia, yet there is no standard protocol for how to deal with eating disorders.
Exposing the systems that are failing young female athletes. Then,
there is no universal single time for anyone to know. What time it is going to depend on everybody's individual location and personal history, how they've been moving around.
The intricacies of time. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station and subscribe and listen to shows anytime on Apple Podcasts and Google Play.
And that's Radio Health Journal for this week. Follow us on Twitter, Facebook, and Instagram to learn more. And check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.